Okay, so let's all get started with spine conference.
I know her, but she, if you're not part of Mercy, she doesn't want to talk to.
So last conference we had predictions, and David predicted the Super Bowl perfectly. He said, "What did you said?"
I said 3 points.
3 points, yeah. So this is March now, so we're going to have different prediction. Who's going to win the NCAA March Madness? So
My name is Clairvoyant.
So we're going to have predictions. What David? Do you have predictions? Because whatever you say, I'm going to put money on it. What's your prediction for the NCAA?
Which one now?
NCAA tournament.
Basketball.
Basketball.
Yeah, I don't follow that.
You don't follow that?
I'm not even sure who's playing.
Okay. All right. Fair enough. Any other predictions?
I think Dunbar is in there somewhere.
Dunbar. Okay. All right. No predictions for that. Maybe next conference. So today's conference is a real patient, and she's 62 years old, and she presented to the emergency room in early January with epigastric pain. So pain just below her xiphoid process along the T12 rib area, and some fatigue. Good morning, Don. And she has past medical history of hysterectomy, removal with benign colonoscopy, high blood pressure, and because of this persistent pain, she went to the emergency room and she was evaluated. She takes metoprolol. She works as a school aide. She's a non-smoker. Her father had skin cancer and thyroid cancer in her mother. She's 5'2", 149 pounds. She has no deficits. Her laboratories, her alk phos was elevated 224, and her white count was 10,000. So any questions so far about the presentation? So just epigastric pain. So she said it's pain and it hurts her at night, not with activity. So in orthopedics, we always ask, does it hurt when you lift boxes, et cetera, to see if it's more of a mechanical thing when you load the joints. But she says, no, I'm fine during the day, but it's at night she had a throbbing pain. So it's a classic, some type of either metastatic or occult process. So any questions about the presentation?
Related to meals?
No.
Associated with vomiting?
No vomiting, no other constitutional signs and symptoms other than some fatigue.
Weight loss?
No weight loss. So while in the emergency room, she, because she had epigastric pain, she had x-rays and the CAT scan. And the CAT scan showed an abnormality, and that's how I got involved. So let's start just with the x-ray. So this is not a trick question, Adam. Just tell everybody what you're looking at.
So you got a lateral view of the lumbar spine, and the bony alignment is normal, the vertebral body height is normal, there's a little bit of disc disease. You don't see the posterior elements really well. You can see that she does have contrast in her colon, and that's not quite as bright as like upper GI or barium enema contrast, so you know that she has had a CT scan. So that nowadays, when I see something like this, I say, I don't really care what this shows because I know she's had a CT scan. Let's look at the CT with the sagittal and coronal reformats.
Right.
Because I could really easily miss something, especially in the posterior elements here.
Mm-hmm.
I mean, you said she's neurologically intact, and
right.
I think the only thing that I would really expect to see on this, perhaps, was if there was an erosion or a fracture or collapse of a vertebral body.
Okay, so just like remember when I was at shock trauma, they'd always say physical exam by CAT scan. Right? So everybody got a full body CAT scan, right?
Would you prefer a CAT scan or an MRI first?
Well,
If you had the choice.
because she was abdominal pain, and she's coming into the ER and a CT scan. Yeah.
So anything else do you want to change on
Knowing
these
that it's
views?
spine conference, I'll say I want an MRI of the spine.
Everybody gets an MRI, yeah. Adam, everyone gets an MRI. So Adam, what do you think of the AP and the lateral here? Anything else?
All right. So you can see she has a little bit of alleloscoliosis. Right where your arrow is on that film there, yeah, right there. It's a little bit hypodense. That the top half or third of that vertebral body is a little bit slightly less dense.
Not as white as the rest of the bone, right?
Yeah.
Which means maybe what?
Maybe that there's an erosive lesion in that vertebral body, but again, that would be, I think, a good pickup if anybody was to call it, on this X-ray. And I think it's probably unlikely to have been called on this X-ray.
Okay.
And she had a CT. Let's see what the CT shows.
Okay, here's a CT.
All right, so now we've got sagittal reformats on the left of the lumbar spine and on the right of the thoracic spine. And so let's see, so we've got 5, 4, 3, to 1. So L1, you know, the first thing you'd say is, well, maybe that's just a Schmorl's node in the invaginating and inferior end plate right there. But then you do have more hypodense marrow in that vertebral body.
This part right here, right?
Yes, and that raises a suspicion of a lytic lesion within the vertebral body. And then I can't, it's really high up there.
This is thoracic.
Yeah, so she has a kyphosis, probably not abnormal for a 60-something-year-old woman to have that.
How about all this white stuff?
The sclerotic enthesophytes, you know, not unusual within normal limits. Then there's the sclerosis right there in that vertebral body.
So that's
Stress
12, 11,
response,
10, 9.
you know.
That's T8.
T8. Okay.
Would you say that's abnormal, or you don't know?
Yes, it's abnormal, but I can't necessarily say that it's abnormal because of malignancy. But it could be abnormal, just previous fracture and healing. And then
Would you comment it on your
Yes.
report?
Yeah.
Okay. Okay, so that's pretty. I think you summarized everything pretty well. So L1. So
And then also just if you're saying that's T8, if you go back to that one, so you know right there in T9, T7. Sorry, go back to the yeah. Look, there's a little bit of lucency right bottom
Where?
down right below right there no, to the and back behind that. Yeah, there. No, in front.
the interior.
There. No, you passed it right over it.
Right there?
There, right behind your arrow. There's
Okay.
a lucency in the marrow, and then a little bit up. You know, there's the marrow.
Hey, Dr. Phil,
is
good
not
morning.
Quite homogeneous.
Okay.
In those vertebral bodies.
Okay. I'm sorry to interrupt you, but let's move along because you're definitely right in everything you're saying. But so just Phil's just stepped down. Just want to real quick. 62, low back pain. Low back pain and epigastric pain. She points below her xiphoid process. She went to the ER, 113, was evaluated, X-rays, CAT scan. Otherwise healthy person, no medical problems. And the CAT scan, Adam was telling us, showed this abnormality basically at L1. So the report said suspicious for a metastatic problem. So this is the real world, like things, like life lives in the real world, you know, so to speak, not in a conference. So the patient calls my office and is like very disturbed. Like, you know, the question is, do I have cancer? And I never met the patient. So now I'm thinking, like, what do I do? So I thought to myself, you know, have them come in, or, you know, have to make an appointment. I'm not sure what it is. And so I think I'll just immediately get an MRI scan. I reviewed all the studies. I talked to her on the phone, just immediately get an MRI scan. So does anybody have any criticism for that? I wasn't sure how to handle it. I usually don't handle these things. No? We don't have to have criticism.
Well,
Should I have seen the patient in the office?
I mean, you know, you're ordering a test on a patient you've never seen.
I've never seen.
And it's a multi-$1,000 test. So
$800, come on.
yeah, that's not what we do. That might be what we accept.
It's about $800 real life. I know. I didn't know what to do. The patient was crying. It was very stressful. So I just ordered the MRI. I'm sorry. That's what I did.
Yeah, I mean, I think clearly if there's something acutely orthopedic, that needs to be acutely dealt with. If something's clearly cancer and there's not an acute orthopedic or neurosurgical thing, then it's like a metastatic malignant workup, because you know most often things are metastases to the spine, and so that sometimes will just give a bigger clue of there's something else going on. You'll probably still need to do what you do, but whether that saves a test or we, you know, get another test to look for what you're going to need metastatically or whatever, that's, you know, we're going to need to do a workup probably.
Okay, so I'm just telling you how things transpired. So here's.
Text us next time.
Okay, I'll text you next time. But I know you're busy though. You know you've got a lot of things. All right, so here's the MRI, Adam.
All right, so on the left is what we call the T2 weighted image, because the CSF is bright, the water is bright, and then it's also fat saturated because you can see the subcutaneous skin, and
Here's
the
the
fat,
fat.
is dark. So the only thing that's going to be bright on this image is generally going to be water. And so if you look in the vertebral body in question, which is the L2 vertebral body,
L1. L1.
Thank you. Yeah. L1, it is bright. So that is then telling us that there is some process going on within this vertebral body that is abnormal and causing this edema.
It's diffusely bright, and the entire vertebral body is bright.
Yeah, the entire. We don't see a focal lesion, but the entire vertebral body
That
is
just
bright.
tell you whatever it is more vascular.
No, doesn't help. Doesn't help.
How about does this?
And then that's a T1 weighted image. Again, the CSF is dark, and so that's just showing you that it's the normal fat that has been in the vertebral body that is bright in the above and below vertebral bodies, the thing that's making those white has been displaced. So the fatty marrow that is normally present within the vertebral body has been replaced by something, and it is edematous.
Okay. Any of this change anything? Pretty
It
much
makes
more
it
the
a little
same.
more defined, but again, we don't see it. It really is a diffuse infiltrating process within the vertebral body, and a malignancy.
Definitely not a
is the most common.
definitely not a Schmoll's node like you thought before. So
Right.
this really changes things.
Yeah.
Okay.
So Adam, is there anything besides cancer that can do that? That's what we want.
Lower
What-
down on the list. It's
what's your
cancer,
differential?
Cancer. If there was an acute traumatic event, I guess there could be perhaps a contusion. I wouldn't expect the vertebral body to be nice and square like this one is if it was a traumatic thing.
If it was
So
a
you'd have
football fracture, it would just be at an end plate, I would say. When kids get these fractures, like football players, it would be just at the end plate, when you say, Adam, at the
Yeah.
top. What about, I have another differential, like Paget's. I think Paget's could potentially look like this.
Paget's disease, though, we expect the vertebral body to be expanded. We expect the cortex to be thickened.
More of-
as
It's kind of
isolated,
the
though?
window frame.
It can be
It
isolated.
can be isolated, right? It can be.
But that's
it's
more
all-
advanced, though. If it's early Paget's, it could look like this. Unlikely, though.
Yeah.
But I've seen 5 cases in like 13 years, 15
Does
years.
it tell you whether, if it is cancer, whether it's more of a solid tumor pattern, or it might be the replacement of the marrow by a myeloproliferative disorder, because sometimes it looks more
The fact that it's completely through the vertebral body is good for a myeloproliferative disorder, but the fact that it's one vertebral body really decreases that. If you had a myeloproliferative disorder like lymphoma, leukemia that was that much in that one vertebral body, you'd expect to see at least maybe islands of disease, I think.
Hold on, Adam. This is T8 before you start talking. That's T8.
Yeah, and then so T8 is the same process, and so now that again, because it's so separate, I think there's really not much else that is going to be doing this.
Okay, and the axial cut
The axial cut,
changes anything? It doesn't have to.
no,
Okay.
the spine is open.
Okay, and here's the lumbar spine.
So now we're looking in the sacrum, and there in the left hemisacrum, there's another lesion that's down there.
Okay. So what do we do now? Does anybody have any, like, what should we do at this point?
I mean, there
Does anybody have any suggestions?
the blood work while the alphas was elevated.
We look at the breast. I think you go to
And
the breast.
see, it says a
You look at the
57
breast?
hasn't had any mammograms.
Mhm.
Is it
So
mammogram?
breast and mammograms. Okay,
Had a
so
CT of the abdomen?
She already
CT
had
of the
that.
ab- she had a CT of the abdomen.
And we
We
didn't
didn't see
see
anything.
colon, liver.
should this patient immediately go to the primary care physician? Should this patient go immediately to Phil? Should this patient go to the orthopedic surgeon? Anybody have any opinions? You don't have to have an opinion.
Oncologist.
Yeah.
Oncologist?
How's she doing clinical in terms of walking?
She's fine. She's totally, except for pain,
Neurological,
no deficits. She just has pain, and she's extremely worried.
And the pain is really severe.
No, not very severe, but just she's concerned. So I didn't know how to do this. So, and in practice, you're busy.
I
You
think it
have.
might be faster if she
Huh?
goes to the oncologist.
I didn't know what to do, so I was like, I'm going to just take care of this myself and see what happens, and God will be the judge, and you guys will be the judge. So I decided, what do I do? So I
You mentioned in the same breath there.
so I said, okay, well, I felt a skeletal. I called her back and I said, I got the MRI report. It looks like a skeletal met of unknown origin, and this was the next day, and I wanted this to flow quickly for her, and I said, in orthopedics, we would. Hold on one second. Pete, we're in the Maryland room. Maryland room, yeah. It's by the front entrance of the hospital. Front entrance. Yeah. Okay. Sorry, it's my friend Pete. He's coming. So, So the best study for this is from Rugraf, who went over a skeletal metastasis of unknown origin. You do a radiographic workup, basically, and it's a bone scan of the entire body, CAT scan, chest, abdomen, pelvis, blood work, and a history and physical. And if you do these studies, you can find the diagnosis 85% of the time, which is great. And if you do a biopsy, that adds 8% for diagnosis. So most of your diagnosis is from this radiographic workup. And why do you do the workup? You want to make sure it's not an isolated sarcoma of bone. But if it's in orthopedics anyway, if it's over the age of 40, it's 1 in 500 chance that it's an isolated sarcoma of bone. So that's usually younger people. You can do the whole workup because you can find an easier biopsy site. So sure, the spine is pretty easy, but there may be something even easier than that. You want to make sure it's not renal cell, which can be very bloody and vascular. And then you would need pre-operative embolization. Maybe sometimes you can avoid a biopsy, and also it helps the pathologist if you have possible diagnosis. So I sent the patient for calcium, serum protein electrophoresis, SPEP, not PSA, but this is just for everybody, ESR, and then liver function tests. I'm not quite sure. And if we just do in the state of Maryland in 2007, by just statistically speaking, the highest probability, I guess, would be breast, and followed by lung, colon, uterine cancer, thyroid. She had a hysterectomy, so that can't be that. And that's okay. So next step now is the further radiographic findings. So, Adam, so she got a chest X-ray.
Yeah, chest X-ray, and there's a nodule in the left upper lobe.
Okay. I'm gonna have to go quickly because there's a lot of stuff. And
there's
the CAT scan.
There on the CT scan of mass. It's not really not a nodule anymore. I use about 2.5 centimeters between nodule and mass.
In the left upper
That's
lobe.
mass.
Okay. And then the bone scan.
Bone scan, you have the skull lesions, the 2 spine lesions, the more sacral lesions than we
T8.
saw.
So T8, L1, and the left sacral lesion. They all light up. Now
Iliac wing lesion there also.
Okay. And
then the interesting that there's the lung lesion, which means it's eroding into bone.
right here.
I was looking the other side there. The second image, right where yes.
Yeah, right up there.
Okay.
To the right.
To the
Right there.
That little thing.
Mm-hmm. Okay. So this doesn't add too much, right? Does that add anything, Adam?
No.
Okay. And
So now we saw that there were skull lesions, so we know that it has diffusely metastasized, and brain lesions would be one that would be become much more urgent for potential just life threatening. So MRI of the brain is very common to do that with contrast to try and find. The skull mets don't matter much, but it would be a brain met that would be very.
her brain MRI was normal.
Yeah.
Okay. Now what? Does anybody have any comments for how we should proceed? And we don't have a diagnosis yet, but
You have a left upper lung mass.
left upper lung mass.
Yeah.
So does anybody have any comments at this point? I can just keep talking.
So you need to biopsy the lung.
You need tissue diagnosis.
Yeah, so I think stepping back, so even though that listed like the most common cancers in Maryland, I mean, really the ones that go to the bone, right? It's like medical school. It's like lung, breast, prostate in a man. Those are the big major players. Renal cell, which is probably the big 4. Rarely gastric can just go to the bone without going into the viscera. But those are probably the big ones. And primary sarcoma of the bone is rare in an older person, and certainly out here I've maybe seen like 1 case in 10 years in someone over the age of like 30. So it's just not on the list. So then you did the pan scan, lung mass. So it's looking like a lung cancer. So if you go with NCCN guidelines, biopsy the met. We want to always biopsy the met because now with molecular studies and immunohistochemistry, you can prove the cancer origin and do a lot of molecular studies on the tissue.
Why not biopsy the primary versus met? What's the benefit?
Because you need to prove the met anyway. Even though clinically it looks clearly like metastases, it's a huge branch point decision tree of like their prognosis. Because clearly metastatic disease, whether it's breast, renal cell, or prostate or lung in general, is not curable versus just isolated stage 1 to 3.
Pete, there's a seat right there. We can't have Pete standing. Pete, please, come on. He's a neurosurgeon emeritus of Hartford County. We can't have him stand. This is Dr. Soteris. Okay.
And often biopsy in the net is more amenable to either a procedure or CT-guided biopsy. It's often less morbidity.
Okay.
So basically, just to again, a segment is that we try to get where the money is, and the money is where the cancer looks more likely. Sometimes the pathologists have some reservations with bone biopsies, particularly in lung adenocarcinomas.
L1
if they don't
mass.
get enough tissue to do some molecular tests.
Right.
So that looks like an easy biopsy to actually to go after. If someone has pulmonary symptoms, hemoptysis, shortness of breath, they might actually benefit many times from bronchoscopy or at least evaluation of pulmonary medicine in case they need to be stented or in case actually they can find an intrabronchial component that needs to be treated right away, at least palliative. But we go basically with the money. Another thing, when you did a chest X-ray, I think most of us would prefer a CAT scan of the chest right from the beginning. We wouldn't really do the chest X-ray first.
No chest X-ray, it's a waste of time.
CAT scan of the chest is not oncology. If we suspect, primary cancer.
Okay, so just a couple things. Intradural versus extradural. 90% of the time, these metastases are extradural, and this one obviously is not even close to the dura. And of 20% of all metastatic disease presents to the spine as a spine met. And then, so the other option we have is fine needle biopsy or CT guided biopsy. So that was an option out there too. CAT scan biopsy, send it to radiology for fine needle biopsy, which is the most common. Would you say way to biopsy?
For sure.
And then very minimal morbidity. And then the other issue is often you have non-contiguous METs, so the whole neural axis has to be evaluated, make sure there's not something else going on. So just in summary, she's 62, and then I saw her in the office now at this point, and she had all these studies. But I had scheduled her for a kyphoplasty and biopsy, and I'll tell you why. I wanted this to go quickly because the patient was very upset. She was crying. It was very stressful, and she wanted to do it quickly, so that's what I did for her. So she's 62, and she had METs L1, T8, and sacrum. She had a left upper lobe lesion, 2 lesions in the skull, epigastric pain. SPEP, UPEP was negative, and we needed tissue biopsy. And the thought process I had was this L1 vertebral body had a change in the CAT scan, which tells you at least 30 to 40% of the vertebral body is now, the trabecular are gone, because you can see it on the CAT scan. Like remember T8, the CAT scan just looks sclerotic, but this thing's lytic. And also the L1 lesion's at risk for fracture. So I told the patient, look, this vertebral body may fracture. It's at a high-risk place. A lot of the bone's gone. It is giving you pain. We can get the tissue diagnosis at the same time, and I can do a kyphoplasty. So that was my goal going forward. And then once I got the tissue, then I'd send it to Phil to go from there. So any criticisms or comments? I mean, I learned from these conferences. So if you think I should have done it differently, you should tell me. Seems reasonable. The other thing is do T8, but see, she said, should I do T8 as well? I said no, because I don't think that's going to fracture because it's splinted by the ribs, basically, and it was not lytic on the CAT scan.
Yep.
Yeah.
Anytime there's instability, so in the spine, any potential neurologic compromise or weight-bearing long bone, certainly the femur, doing ortho stuff first, provided there's not a risk of pulmonary hemorrhage or they have small cell lung cancer, something we need to get going sooner, and that's clearly going to benefit from the chemo portion. Should do the ortho first, stick a long rod up their femur, stabilize their spine, whatever, because we don't want to do that mid-treatment.
Mm-hmm.
That's my feeling in general. And then the easiest way to biopsy, I always just go for the money if that's easy, but certainly CT guided, or if you can fold it into a preventive procedure, one procedure is always better than 2 for the patient. That's the bottom line.
Right. So those were my thoughts, and I didn't want this to happen. I didn't want her to get a fracture because usually they don't have a neurologic injury, but it is possible, and then it's more painful. It's more difficult to treat. So I did a kyphoplasty, and oh shoot. Hold on, I have.
See what that is.
There's going to be a joke. Do you guys? How much time do we have?
Conference is this?
Huh? No, this is a fun conference. This is a fun conference. Hold on, and I'll show you guys. I'm going to show you guys the. Unfortunately, it's not working. Give me a second. I wanted to show you guys the kyphoplasty video. No, it's not working. I'm not connected to the internet. Okay, I had a video of the procedure, but that's okay. All right, I'm sorry. Just give me 1 second, guys.
Well, while he's getting that up, I'll just comment that I think it's been perfectly managed. I think you managed it very well. I've been in similar situations as a radiation oncologist where I do the entire workup just for expediency. And I think that you were able to do all of it, order all the proper studies, is to your credit. And I think that has done the patient a good service. Because otherwise, when you refer, there's time to get the patient in, just a lot of time goes by. And a lot of times people are very upset, they just can't wait, it's got to be done.
Stressed, yeah. And okay, so she had an L1 kyphoplasty, and I had the video, but just for time's sake, I'm not going to show it. So now, this is just in general, so you guys understand how medicine works. This will be just a quick joke. Doctors sometimes they fraternize. So we all went duck hunting one day, and this is me. I organized the trip. This is Pete Ladakis, the oncologist. This is Dixon King, our pathologist, and our radiologist, Adam Morgan. So we all went duck hunting, and it was in Harford County, but there was a bald eagle nearby. They said, the sheriff said, you have to be careful, don't shoot a bald eagle, it's got to be a duck. We said, fine, we won't do that. So we go by, the first person we said was going to be Pete Ladakis. So Pete Ladakis sees the ducks quickly, and he says, I know by this time of year it should be a duck, but you never know, it may be a bald eagle, but percentage speaking, it's probably a duck. And by the time he thought of this, he shoots and he totally misses. The duck goes by. So then the second duck comes by, and it's Adam's turn. So Adam's looking. He's like, it looks brown, but maybe white, but it's not well described in this area. And then by the time he shoots, the duck is gone. So then the next turn is the surgeon's turn, my turn. So the minute the surgeon sees the duck, blam, 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 shoots it down, the duck falls, and then he turns to the pathologist, go see what I shot. So that's the orthopedic. That's a classic doctor joke, right? Okay, so now it's Dixon's turn.
So this is the biopsy that we received, and as you mentioned, someone mentioned, oftentimes we'll literally have bone, and we'll have the marrow, and then we'll be looking for just a few cells to try to make the diagnosis. This is very different. This was very easy. This is tumor all throughout here. Have you got a pointer or?
Yeah, you can.
Or I can just.
You can use that. You just use that. That'll work. Just put it on the ground. See it?
Okay, so the red here is the residual bone, and basically all of this blue is tumor, all through the narrow spaces here. So all of this is tumor. And can you hear the next one? Or
Yeah, just say next slide. I'll do it.
So again, this is the bone, and this is all the fibrosis that's associated with the tumor, and these are the islands of tumor here. So basically your first differential is this an epithelial or or like a plasma cell or lymphoma? But this is an epithelial tumor, and is it small cell versus non-small cell? This is not small cell. So you're dealing with a non-small cell met.
Can you tell everybody why it's not small cell?
So small cell has a very different look. Basically, you're looking at just nuclei with small cell. You have molding, you have very little cytoplasm. So literally they are usually very small, and they mold together. You get necrosis. Whereas this actually has, you get a higher power. Let's just go with the higher power. Here you have nuclei, but you have quite a bit of cytoplasm. So all of this is cytoplasm here, and then the very dark is basically the nuclei. And the other thing that you have is you're forming glands here. So again, now you're beyond just non-small cell. You can say with a fair bit of confidence this is adenocarcinoma. So again, with non-small cell, you're thinking more squamous cell versus adeno. So here now you're into the realm of adenocarcinoma. So you've got a good diagnosis already. You've got metastatic adenocarcinoma. Again, the gland formation is fairly specific for adeno. Sometimes you'll even see mucin within this, and only adenocarcinoma usually produces mucin like that. So go to the next one, please. And at higher power, again, these cells are very poorly differentiated, but there still is a fair amount of cytoplasm. All this pink is cytoplasm. Here's a mitotic figure here. And you can see kind of this abortive gland formation here and here. So you have fairly high confidence that you're dealing with an adenocarcinoma.
How do you know that's a gland?
Well, if you think about kind of the normal gland, you have the nuclei kind of lined up around the outside, and you form a lumen here, and so you kind of have to use your imagination. But this is the same thing here, the same thing here, and in some respects they kind of line up around that lumen. You have to use your imagination sometimes more than others. But in a nice benign gland, you have the lumen, you have the cells kind of lining up around the lumen, which they usually secrete into the lumen. In adeno-CA, to varying degrees, they do that. In poorly differentiated tumors, you may only have a few little glands. In well-differentiated, you have more glands. And this is maybe even like a little signet ring cell here, where you have a single cell that's producing mucin there. Next. So then we do special stains. So does anybody know what the absolute best special stain we have is? We have hundreds of immunostains. What's the best one?
I have no idea.
A good history.
A good history?
It's the best special stain. Because again, we've got hundreds of stains, and oftentimes we'll be looking at this. This can be a lot of different things. And then we'll say, what's going on with the patient? Oh, did I mention there's like a 4-centimeter breast mass? Did I mention there's a 4-centimeter lung mass? So that really, really helps us to have a good history. Because otherwise we're just kind of shooting in the dark, and we have our kind of like standard things that we go through, but knowing what's going on clinically makes a huge difference. So in a situation like this, there's a couple of stains that we use right off the bat. CK7 and CK20. They're basically cytokeratin stains. And the pattern of CK7 and CK20 positivity really helps you kind of narrow it down. So this is the CK7, and so it's strongly positive in the tumor. All of this brown staining is the positive. So CK7 is strongly positive, and then next one, please. And as opposed to that, this is the CK20, so CK20 negative. Unfortunately, some of the most common things are CK7 positive and 20 negative. The big ones being lung, breast. In a woman, adeno-CA of the endometrium. Pancreas is also positive. Pancreaticobiliary tract is positive. But again, knowing that you're dealing with a woman, knowing that you're dealing with a lung mass, that really, really helps. So now we've got a CK7 positive, 20 negative adenocarcinoma. So then again, we try to narrow it down. So go to the next slide, please. So one thing that we have used for years is TTF1. This actually means thyroid transcription factor, and it is positive in thyroid, but it's also positive in about 2/3 of lung CAs. In this case, it's completely negative. If you have TTF1 positivity with a lung mass, we can say fairly confidently this is metastatic lung, but this is completely negative. And recently, I'd say in the last 3 or 4 years, we've started using another lung stain that's fairly sensitive and specific, which is called napsin-A. Let's go to that slide. And this positivity for the napsin-A is, again, fairly sensitive and specific for adeno-CA of the lung. So even though the TTF1 is negative, the napsin-A is positive, so we can say this is most consistent with metastatic adenocarcinoma of the lung. If you just do the TTF1, you're going to miss about 11% of lung primaries. So oftentimes we'll do, or lung mets. So oftentimes we'll do both the TTF1 and the napsin-A. In this case, it was very good that we did that because we would have not been able to say it's lung primary. Here we have a CK7 positive, 20 negative, napsin-A positive, so that's fairly consistent with a lung primary. I think that might be all.
What's the reverse of that? The napsin positive, if napsin's negative, why do the TTF1 if it's napsin better?
Well, a couple of reasons. Actually, the napsin-A is kind of difficult to interpret. The TTF1, when it's positive in the nuclei. So the nuclei are just stone cold positive. It's easy to look at. It's easy to diagnose. The napsin-A, it leaves some room for interpretation because you can get kind of non-specific, see all of these granules here? You can get a little bit of non-specific granularity even in non-lung CA. You really need to look for these big ones, big globules like this to really call it positive, and that can often be difficult to interpret. If you have the TTF1, you have a lot more confidence. And this, I had to actually look around in the biopsy quite a bit to find a few positive areas like this. So again, it's just kind of your confidence level. If the TTF1's positive, we feel really, really good about that. The napsin-A is a little harder to interpret, but if you have the good, big globules like that, you can say with, again, a fair degree of confidence that you're dealing with lung. So that may be the last one. Let's see. Yep.
That's it. Okay, so let me just, does anybody have any comments about the pathology? That was great. Now, I have one question actually. Did you do all the stains at once, or you do them one at a time, seeing what comes out positive?
That's
negative?
always a difficult question because again, you're dealing with a time factor. You know, you've got Phil calling me over here the next day saying,
Right.
"What is this? What is this?"
Right.
And so, again, you have to kind of use judgment. And you if you have an unknown primary, you kind of, and if there's no big rush, you can kind of go in steps because each one of these can take a few days. If we do them in-house, we can usually get them out the next day. Some of the more specialized stains, we don't have the facilities to do them in-house. We have to send them out. That might take 2 or 3 days. So again, you kind of have to weigh these things. And so in this case, again, if you know that there's a big lung primary, probably you can kind of focus on that and do some of the stains kind of right at the front to say, oh, this is probably within a few days going to be an adenocarcinoma of the lung. If you have a totally unknown primary and you get a bunch of negative stains and you got to go through another round and another round like that. So oftentimes it is difficult to kind of make that decision, kind of cost-benefit ratio.
Okay. So, okay, thanks. So, any other questions?
When
for
you see
Dixon?
that it's probably a lung adenocarcinoma, do you immediately send out material for EGFR mutation?
We do now at the request of the oncologist. Again, in the past we kind of said, we'll leave it up to you guys. You just kind of tell us. But now, standard of care, adenocarcinoma of the lung, we go ahead and send it out for the KRAS EGFR and outpatient.
Tell everybody what EGFR is.
Epidermal growth factor receptor, and certain mutations actually are implicated with various management approaches, and tumors that they carry certain mutations, they are amenable to treatment with oral agents, so it makes a huge difference in adenocarcinoma of the lung. So instead of giving IV chemotherapy with a very different spectrum of toxicity, you can just give them a pill, and the overall outcomes are actually comparable. So there's a shift in the paradigm of care in the management of metastatic adenocarcinoma of the lung, and with those agents over the past few years. And we do have more and more in the pipeline. We do have more tests of a fusion gene called ALK. So one of the issues that comes up in conferences, and we see it all the time, I think, is that there is always this complaint, and we complain. We often complain there isn't enough tissue, there isn't enough material. So unfortunately, with adenocarcinoma of the lung, now we need more and more. So there is always the question of which ones do you do first, and whether you have enough tissue to do more, and whether we should do ALK first or we should do EGFR mutations. Always try to do, because there is a treatment implication. But sometimes I had patients who we didn't have enough tissue, and sometimes because it would make a difference, they had to go back and do another biopsy. And that's not really very pleasant for the patient. Another thing that comes up is a question from our point of view, I think, is, and correct me if I'm wrong, is sometimes the diagnosis comes up as adenosquamous or adenocarcinoma with squamous component, or like a mixture, which again doesn't help us, because now the management of metastatic lung cancer is different whether it's actually adenocarcinoma versus squamous. So that kind of complicates the things from our
We
point of
try
view.
very hard to avoid adenosquamous, and I'm not sure it's been a long time since we've come up with that diagnosis for you guys lately. And we have even like for squamous now we have P40, which again is just in the last year or so we've used because it's fairly specific for squamous cell. So we really try to avoid that because we know the implications now, and so we really try to do the stains that we can at least tell you definitely adenocarcinoma, definitely squamous, and only as a last resort say like adenosquamous.
Okay. Right. Anything else?
Well,
good?
yeah, I think just the backstory, just for people as this evolves in the cancer center over several years, is like whether this will change clinical management or not, we don't know. But the latest topic is you can sequence your entire genome now, okay? And so you can sequence the human genome was sequenced in like 2003, and so you can sequence there's a cancer genome atlas which is going to be finished probably in the next 5 to 10 years.
How much is it? It's like $5,000, isn't it?
So the
for your
price
whole
is coming
genome?
down. So the whole genome used to be, several $1,000s, even hundreds of $1,000s. But now there's third generation Sanger sequencing, if you remember from molecular biology. And so within 5 years, it's going to be under $1,000. And so whether this is important for clinical applications or not, we don't know. But let's say for breast cancer, we have some assays where you can look for compilations of certain genes, like 21 gene assay, like something called the Oncotype, where you can predict a person's prognosis in a certain subset of patient. And this is maybe entering colon cancer, this is maybe entering other cancers, So we know that same breast cancer, that same lung cancer, that same adenocarcinoma, it actually looks the same maybe under the microscope in our old certain immunohistochemistry, but actually from a molecular level, if you sequence the entire genome, there's maybe 200-300 different patterns of genomic sequencing, but actually they can be divided into maybe like 5 to 13 different driver patterns. That's what Bert Vogelstein at Hopkins describes. And so each of those maybe has potential targets for different drugs, like Dr. Ladakis mentioned. And so that's what you're going to see evolving. So the first iteration of that is crude things like checking EGFR or 1 or 2 different genes to see, because we currently have a drug for that. And that's what we are now in this first generation of exploration. But over time, there's going to be, you could potentially get, there are companies now where you can sequence your whole genome. We don't know what to do with that information, but someday you might have some idea what to do with that information. So just to keep in mind out of the ortho context.
And is it sequencing?
Stop rolling
No, I
your
like it.
eyes.
I like it.
Is it sequencing the DNA of the patient or sequencing the DNA of the tumor?
You do both.
Okay.
You do both, and then actually you can do what's called
Panels.
competitive hybridization. You can see what's different. And then if there's a drug to target that difference in a pathway, then that's what you're going to target to avoid hitting the normal. You know, now whether that actually translates to improvement in survival versus cost benefit, honestly, I'm quite skeptical of that. It's a big boondoggle, but you're just seeing a huge drive towards that.
So gene expression profile, and there's different tumor style too. You start doing it as
No,
anyway, so you're gonna.
it's not covered by Obamacare, I'm sure.
Yeah, but we still want to, crack bones, right, for it?
Right.
Right.
All right, so let's keep moving because we're on schedule. So most of these things present to pain as me, and it's, as a physician, I find it sometimes very difficult because I hear a lot of noise when it comes to pain. For example, if you have kids, everybody's got something painful one day, and you're the doctor, you have to always check it out. It's usually nothing, but sometimes it's not nothing, it's something, and it's very difficult as physicians to understand what's real and what's not. So just a couple statistics is in 2012, new cases of cancer was 1,638,910, which if we have 314 million Americans, that's 1 in 192 every year. So your chances of getting a new case of cancer is 1 in 192. And the age group, unfortunately, I'm starting to get in this age group now, but the most common one is 51 to 60, so I'm getting pretty close. A little bit depressing. So the metastases, like Phil says, lung, liver, and bone are the most common, 1, 2, and 3. And just so everyone knows, you get the cancer, and then it has to invade, you have to have blood vessel formation to the cancer, and then the cells have to invade into the vein, the capillary vein, and then travel along the body without getting eaten up by a white cell. And then they have to lodge into, at the end capillary area, they lodge into a bone area. And then once they lodge in there, they have to proliferate. So there's a lot of steps that go into metastases for them to actually metastasize. And in this case, I believe it goes through veins. And the question is, how did it get to the spine? Well, it got to the spine through Batson's plexus. And you may say, what's Batson's plexus? It's a valvulus, there's no valves here, it's a plexus of veins that go through mostly the spine. And this is Batson, I looked him up, Oscar Vivien Batson. He was at the University of Pennsylvania, and apparently he was a very stoic, really tough guy. And he studied prostate cancer, and he inserted a catheter into the dorsal vein of the penis of the chimpanzee. I'm sure a tech must have had to do that. He didn't probably do that. And he did he pushed the dye into the veins, and it went up the normal venous areas. But he found when he did a Valsalva maneuver on the monkeys by pushing on the chimpanzee's stomach, it went into the spine. And he showed the venous plexus of the spine. And this, so anybody's question, this is Valsalva. He was an Italian anatomist he did the Valsalva maneuver to eject pus from the ear. That was what he used it for. So if you think of a Valsalva maneuver, all the pressure of the abdomen, it pushes on the IVC, which increases the venous pressure. And then it goes into the Batson. But also in the spine, when we do this, it also makes CSF leaks. It causes intracranial pressure as well, because all the veins engorge in the brain, and push onto the brain and CSF, and it makes a CSF leak. Is that right? Would you a good way to describe it, Pete?
I think it's reasonable.
Yeah. So what my question is, why so many mets to the spine? Because usually we're not coughing. Usually we're not having a bowel movement. Like, why does it go so often to the spine? I mean, most cases go to the spine. Why is Batson's plexus so important? I mean, I have no idea. Does anybody have any idea? I mean, I would think it would just go to the enormous venous areas. Anyway, the most common mets to the bone are breast, prostate, lung, renal, hematopoietic tumors, and thyroid. And about 70% of all metastatic disease eventually goes into the bone. And then the question is, if the spinal cord is compressed, do we do radiation, just radiation, or radiation plus surgery?
Yeah, actually, I mean, what's the role of radiation after kyphoplasty? What's the timing? I mean,
What do you think, Vladimir?
Well, yeah, usually after kyphoplasty, we would do radiation in order to just eliminate the residual cancer there. Because if it was bad enough originally to cause the problem, we want to make sure we sort of sterilize that area and not have progression, local progression. So generally after kypho, in a pathological fracture involvement type of situation, we do give post-procedure radiation. But the setting is important too. Obviously, if the patient has progressive liver mets that is and the systemic therapy is very urgent, I would pass on doing that because I don't want to waste any time. But usually we could do it fairly quickly. And I have some slides we can show a little bit. In fact, this patient, I have her treatment slide.
Okay, let's do the slides. I have other stuff. We'll do your slides.
If you just get in. This was Dr. Horvick's case, but I am a little bit familiar with the case. And so here there were 3 sites of disease that were primarily causing pain and or significant involvement of the spine. And we have a machine in the department called a tomotherapy machine that, unlike usual linear accelerators, the tomotherapy machine has the patient go through, it's like a CT scanner, and the radiation is given helically as the patient is going through. So we have much less field size limitations. In fact, I would say that for a tomotherapy machine, there is no field size limitation. So we can treat much easier multiple sites, like in the spine, all in one shot. So this shows, for example, that I believe it was the T8, the L1, and one additional site of disease was treated here, here, and here. And this kind of just shows how, as the patient goes through, this is receiving radiation, this is receiving this. So it's done very quickly, and it's a very, elegant way to do it. Oh, if go ahead and get out of that.
Okay.
I have a couple of slides just briefly to show about some of the newer things in spinal radiation. Maybe down. Here it is.
I'm sorry. So use the pad, the finger pad.
See this one? The one next. If you can open up this.
Spine mets?
Yeah.
So in this case, are you picking the max gray based on the tumor or the location or both? Or
I believe the prescription. Yes. If you can just open that up. The prescription here was 300 centigrade times 10,
right,
which this is probably the most standard and most commonly used dosing scheme for palliation of bone mets in the U.S. It's 10 treatments of 300 centigrade. It's a 2-week course, and that's what she's receiving.
So if this was, let's say, renal cell or some other less or more radiosensitive tumor,
Yes.
would you change the dosing
Well,
in this clinical circumstance, or it doesn't affect that?
Traditionally, it's been the same dose, no matter on the radiosensitivity, but that's starting to change now. In fact, I'm going to show you a trial.
You want to go down?
Go ahead, next slide. I'll show you a trial here. If you could go to the first slide.
Which one?
Basically, this right here. So, if you could, actually, I'm sorry, go back one.
Back?
Yeah. Back again. Yes, here we go. Okay. So historically, there was this RTOG trial, 9714, which randomized the most common scheme, 300 times 10, to one treatment, 800 times 1. and the results were equal. Basically, this was for bone metastasis, and specifically for spine mets, 61% of patients experienced partial or complete pain relief at 1 month post-treatment, and that's not that great. So we're looking with new technologies, next slide, we're looking at other ways to improve upon this 61%. So with basically this stereotactic radiation that is becoming more and more common, this is a higher dose radiation that's given much more precise to the tumor. And we're starting to look at, well, what about treating individual vertebral bodies with stereotactic radiation? And so there's been some preliminary data, phase 2 data and retrospective data that show that using the stereotactic high-dose treatments in a single fraction, and not 8 gray, now we're talking about 16 to 18 gray in one treatment, actually produced rapid pain relief with median time of 2 weeks to pain relief, and in some cases as early as within 24 hours. So the early data showed us very good, and the duration of pain control was very long, median over a year, and the local control also was 95%. Next slide, please. So in fact, this is the topic of a new RTOG study that's looking at image-guided stereotactic radiosurgery for localized spine mets, 1 to 3 spine mets, and the dose is 1 treatment of 16 gray versus 18. Next, this is how it breaks down. And here, for the first time, I would say, we're looking at radiosensitivity of the tumor as part of the analysis. And so this is sort of how it breaks down. It's a randomization between 8 gray in a single fraction versus 16 to 18 gray. The next slide. I actually ran the CyberKnife unit in Harrisburg before I got here, and we started to do this study there. And so this is an example of a patient I treated with a single level metastatic lesion. And you can see how the spinal cord here, the main challenge of this is you have to relatively avoid the spinal cord. So you can see how we're treating the anterior vertebral body, including the pedicle. This is the lesion, and the orange line is the line that we're actually prescribing the full radiation dose to. So you can see how we are avoiding the spinal cord, and it still gets some dose, but within tolerance. So next slide. This is just another picture of the case. Next slide. This is the second patient that actually had 2 spinal metastatic lesions. This is an image of treating the anterior vertebral body in 1, and then next slide. And this is actually, the lesion was in the pedicle here, and so we're treating this area here, avoiding the spinal cord. Next one. This is how the protocol recommends to define the target volume. And so basically, if you have a lesion in the anterior vertebral body, they recommend treating all of it, not just the lesion, including the pedicles. And so if it's posterior, you always try to include the pedicles because that's a very common place that it's also involved. Okay, next slide. And this is just a chart of all of the doses that we try to be less than. These are the tolerance doses. The most important is the spinal cord. So we look at that very carefully. What volume of the cord gets certain doses of radiation. So both of these patients that we did, next slide please, had very rapid pain relief, and in a single fraction, 1 treatment. So it's very nice. And the top picture is the CyberKnife, and this, what we have here, it's actually made by the same company. Accuray owns both of these pieces of equipment. We have this tomotherapy unit. So what I would say is, for this treatment of this stereotactic single dose, it could be done on either one of these machines with very equivalent dosing. That is the result, those doses I showed you. So I would say it's equivalent. The CyberKnife is a little bit, if not worse, maybe just because the time, because the radiation comes out as a pencil-thin beam, it takes a long time to treat the patient. It could take an hour or more to get this treatment completed, whereas with the tomotherapy unit, radiation is coming all around from 360 degrees, and it's much more rapid delivery. We can get a treatment like this done, within 10 or 15 minutes.
Most of the RTOG, if I know, the stereotactic SBRT is not done on a CyberKnife unit type thing, right? I mean, most of the trials have been.
Yeah, this particular protocol actually I showed is for a LINAC based.
Right, most of
Yeah.
them are Linux data.
LINAC based. But these two machines, I would say, are even more well suited than a regular linear accelerator to perform this. But yeah, so
That's basically all I had. So any other questions about anything?
Systemic therapy?
Oh, no, please.
No, go ahead.
So she came, so Spiro referred her to me, so he had already teed her up. So her molecular studies were negative. And so, we staged her. She's stage 4 adenocarcinoma. So the NCCN, the National Comprehensive Cancer Network, there's different guidelines. So not all non-small cells treated in the same way. And so our clinical trial, we do have a clinical trial for her. So we're doing 4 cycles of a certain regimen, which is the standard of care. And then she's going to be randomized to an angiogenesis inhibitor, sunitinib, afterwards. So we'll see. So she's getting the standard of care plus potential to get potentially helpful agent. Median survival, across the board, this has been studied for like several decades with stage 4 non-small cell. Without molecular mutation, I mean, improvement of chemo, you can 6 weeks is maybe the low, maybe you can get several months. That's an average. We've all had patients who get a lot more than that, and some get much less, but really the benefit is not huge in a person. Actually the best clinical predictor still remains what we call performance status. So it's just the old basic ECOG cooperative group performance status, which is a simple rule of thumb. And I just say that if more than half your day you're up and functional around, you have a 0, 1, or 2 basically. More than 50% of your time you are clinically have potential to benefit from treatment. If you're really in bed, you're down, you're lethargic, in general, it's going to make your quality of life and survival worse. There's new data that was published by Tom Smith, who's a palliative care doctor at Hopkins, but he was at Virginia Commonwealth. Early palliative care implementation in almost all metastatic diseases, but certainly in lung cancer, improved survival up to 3 months, in some estimations. And so that's why Angela Poppy-Reese here, who's our palliative care doctor, we've kind of had early implementation of palliative care with all of our metastatic patients now. So they're getting chemo, but the minute it's not looking good, we're doing symptom management, and then it's boom, hospice care. They're living longer with less morbidity and less cost to the society. So that's my approach on that.
Okay.
Modify the thing with bisphosphonates, right? And because of the skeletal related to that. So
That's right.
Yeah. We have a group of medications, bisphosphonates, or and actually an antibody, monoclonal antibody against RLK called Exiva or denosumab, that people with proven skeletal mets, bone mets from lung cancer, prostate cancer, breast cancer can receive on a regular basis as a prevention for future skeletal, SRE, skeletal-related events, basically bone pain, pathologic fractures, and core compression. So there's some benefit there. Is the institutional trial only to ask you, or
Well, we're linked in Maryland, so so it's part of Virginia and all here. Yeah, we're in a line site now.
So you have your own institution, your IRB, or they use them through the center of the
Actually, so we have our own. We're linked to theirs, but over the next 6 months, Alliance is going to centralize them at NCI. So once it's NCI approved through the IRB, all peripheral sites won't have to approve as long as you agree to go with NCI's approval.
So Spiro, did her pain go away from the kyphoplasma?
Improved.
Yeah, okay.
Mm.
Yeah, pain's better. She's finished her radiation.
She is almost done.
Done, and then she's set for chemo soon. Yeah, next week.
Great. Thank you, everybody,
Thanks,
for
Phil.
coming. That was a
Very
very nice conference. Thanks, everyone, for
Thanks,
coming.
Phil.
Thank you, Phil. Thanks. Thanks for coming. Rebecca, I'm on my way. Okay. Sorry. Right there. Forget it.
Thanks very much.
Oh, Vladimir, it was really nice to meet you.
Thanks for the invitation.
Yeah, anytime. If you would like to present a conference or a talk,
Okay.
contact me anytime.
Okay, sounds great. Okay.
Thanks
Thank
for
you.
coming. Okay.
Okay, take care.